So, good afternoon. Today I'll be talking about approach to patient with abdominal mass. Now, look at this. This is what we tell our resident. Principle of clinical diagnosis. When you make a clinical diagnosis, be like a fisherman. The fisherman makes his net very wide first. You know why? Because he wants to catch as many fishes as possible over a wider area. Similarly, when you make clinical diagnosis, let us say there is a right iliac fossa lump in a patient presenting with abdominal pain, just don't say, sir, intestinal tuberculosis or ileocecal tuberculosis. Don't say that. You say that is this lump intraperitoneal or retroperitoneal, or in other words, first you say intra-abdominal or extra-abdominal or parietal. Then we say intraperitoneal or retroperitoneal. Then you say you are expecting this lump to be malignant or benign. And then you say what could be the etiology. So that is making the diagnosis wide rather than in a very narrow footing. So this is the principle of clinical diagnosis we'll discuss in detail in next 1 hour. And this is a book that I'm now working on. And this is clinical and bedside approach to patient with digestive disorder, and a lot of things I will take from this book. Let us come to a patient. This is a 55-year-old female who came to us with a lump in right lower quadrant. It was 6 months in duration, progressively increasing in size with constant heaviness and discomfort. She also had anorexia, but there was no weight loss. She had this pain which was dull aching for last 6 months, got little more in last 3 months. It was constant. There was no radiation to the back or groin, no specific aggravating or relieving factor. In addition, she had 2 episodes of periumbilical pain of moderate in severity, which was colicky, had associated borborygmy lasting for 2 to 3 hours. It was associated with a mild mid-abdominal distension. One of the episodes had bilious vomiting and there was no GI bleed. So analyze this history very carefully. Now look at here that there are 2 types of pain. One type of pain is dull, aching, right lower quadrant pain. And the other type of pain is colicky pain, suggesting that there is a subacute intestinal obstruction. So you can make out from here, we are talking about a patient who had a progressively increasing lump with subacute intestinal obstruction, suggesting that it is causing some narrowing of the lumen. When you present the history, now give all the negative points in the history. And when you say negative point, just don't say no history of GI bleed, no history of diarrhea, no history of flushing and wheeze, not like that. You just say no history of GI bleed, diarrhea, flushing or wheeze, fever, trauma, hematuria, oliguria, dysuria, renal colic, hypertension, palpitation, sweating, tremor, syncope. She was postmenopausal and there was no history of postmenopausal bleed. Why are you doing that? All this negative history helps us to exclude something. Like when there is a patient of right iliac fossa lump and I'm talking about flushing and wheeze, obviously I'm meaning carcinoid syndrome. When I'm talking about hematuria, oliguria, dysuria, renal colic, I'm trying to say that this lump is not related to the kidney. On the other hand, when I'm saying hypertension, palpitation, sweating, tremor and syncope, I'm trying to say this lump is not an adrenal lump, though location is not really like an adrenal lump, but still we are giving this history because when patient localizes, it may not be a great localization, there could be mistake. So this is hypertension, palpitation, sweating, tremor and syncope is referring to pheochromocytoma. When I'm saying that there is no history of postmenopausal bleed, obviously I'm talking about the obstetric and gynecological condition. So do 2 things. One is don't say no history of each time. That is one thing, must be avoided. And second, what you do is that organize this negative history in such a manner so that each of the group actually exclude one particular disease or related diseases. Now let us come to how to analyze the history. Analysis of history is very, very important. Now, abdominal pain, what to ask? If you look at the way I took the history, there are certain points that I refer to. I refer to time of onset. I said 6 months ago, aggravated for last 3 months, but I also said there are 2 separate episodes which were sudden in onset and severe in nature. Mode of onset, duration, site of the pain, character of pain, shifting of pain, radiation, referral, aggravating and relieving factor. Each of these I'll discuss now. Abrupt onset, typically mesenteric infarction, perforated viscous and ruptured aortic aneurysm. These are the 3 conditions where you get a very severe pain of very abrupt onset. Mesenteric infarction, the pain will, the onset will be in second, perforated viscous and ruptured aortic aneurysm. Acute onset, not in second, obviously it is in hours. These are pancreatitis, appendicitis and cholecystitis. Chronic onset, chronic pancreatitis, irritable bowel syndrome. Now duration, short duration means these are acute conditions. For example, appendicitis and cholecystitis. Long duration are chronic conditions like chronic pancreatitis or malignancy. Remember one thing, pain out of proportion to abdominal sign. So patient, when you examine the abdomen, you find there is nothing wrong, but the fellow is sort of getting a very agonizing pain. Suspect pancreatitis. Second, always suspect it could be mesenteric infarction or ischemia as well. And when you talk about mesenteric ischemia, look at the setting. The setting is he's an elderly man with associated cardiac disease. Okay, there are atherosclerosis, hyperlipidemia. This is a classic setting of mesenteric ischemia. So, because these are retroperitoneal organ, for example, pancreatitis is a retroperitoneal organ. So you will not get much shine in the abdomen, but the symptom will be very severe. Pain will be very severe. Similarly, mesenteric ischemia, the sign will be much less unless there is gangrene or perforation, but the symptom will be very severe. So in all patients of acute pancreatitis, just keep in your mind, could it be mesenteric ischemia? Now location is important. For example, right upper quadrant pain can be due to cholecystitis. But if you read Schlesinger, you will find 50% pain in the right upper quadrant in cholecystitis, around 20% or 25% pain in the epigastrium, and 5 to 10% pain may be in the left upper quadrant. Liver abscess and hepatomegaly. These are causes of right upper quadrant pain. Left upper quadrant pain, splenic infarct, colonic ischemia, inflammatory bowel disease. Central pain, pancreatitis, biliary colic, peptic ulcer disease, and intestinal colic. Right lower quadrant pain, appendicitis, mesenteric adenitis, amoebic colitis, pelvic inflammatory disease, tuberculosis, and inflammatory bowel disease such as Crohn's disease and neoplasia. Left lower quadrant pain, always remember diverticulitis. So diverticulitis can cause sudden severe left lower quadrant pain, inflammatory bowel disease, pelvic inflammatory disease, colonic ischemia, and neoplasia. Now these are the quadrant of abdomen which you all know. Now character is important. For example, colic suggests there is an obstruction to hollow viscous, and I'll tell how to make out colic. Constant burning pain suggests peritonitis. In fact, peritonitis patient will like to lie like a standstill. They will not like to move because you know each time he tries to move, the pain will get aggravated. Severe agonizing pain is pancreatitis. In peritonitis, if he presses the area, like if he lies sort of prone, pain may get increased. But in pancreatitis, pain may decrease. Throbbing pain is cholecystitis. So shifting of pain occurs because of inflammation of viscera. For example, first it involves the visceral peritoneum. Classic example is appendicitis. In appendicitis, first is it involves the visceral peritoneum on the or lining the appendix. Because appendix is the nerve supply is T10, T9 to T10. So you get the pain around the umbilicus first. And then later the appendicitis causes inflammation of parietal peritoneum, and the moment parietal peritoneum gets inflamed, your pain shifts from umbilicus to the right iliac fossa. So that is shifting of pain. From epigastrium to back, pancreatitis. Why? Because pancreas is a retroperitoneal organ. So if it is a retroperitoneal organ, the shifting of the pain or referral of the pain or radiation of the pain happens to the back. Epigastrium to right iliac fossa, perforated peptic ulcer. It is because, suppose let us say there is a duodenal ulcer which perforates, the content of the intestine will track down the paracolic gutter and will collect in the right iliac fossa, and that will lead to radiation of the pain from epigastrium to right iliac fossa. Referral to the inferior angle of scapula, biliary colic, to the shoulder, subphrenic abscess and biliary colic, loin to groin, renal colic, lesion in the stomach and jejunum, there will be referral to epigastrium, ileum and appendix, initially to the umbilicus, because this is the nerve supply of the umbilicus is segment 10, and also appendix is supplied by segment 10, and colonic pain will be hypogastrium. Aggravating factor, gastric ulcer, food aggravates the pain, whereas duodenal ulcer, food may relieve the pain. Stooping will aggravate the pain of reflux esophagitis because there will be more reflux. In cholecystitis, fatty food will aggravate because fatty food causes contraction of the gallbladder. Rolling will aggravate pain of peritonitis. That's why this patient will like to lie, stand still. And inspiration will aggravate pain of diaphragmatic irritation. Relieving factor, vomiting relieves the pain of intestinal obstruction. Leaning forward relieves the pain of pancreatitis, but remember, only 50% of the patients with pancreatitis will give history of pain getting relieved by leaning forward. Food relieves the pain of duodenal ulcer, but it aggravates the pain of gastric ulcer. So abdominal causes of acute abdominal pain. So abdominal wall, trauma or infection of the muscle, inflammation of parietal peritoneum like peritonitis, hollow viscera obstruction such as small and large intestinal obstruction, biliary tree obstruction, ureteric obstruction, vascular causes like thrombosis or embolism, vascular rupture, sickle cell anemia can cause severe pain called sickle cell crisis, distension of the visceral surface of the peritoneum and hepatic and renal capsule can also cause abdominal pain. On the other hand, you can get acute abdominal pain in absence of abdominal disease. For example, diabetic ketoacidosis. They can present with acute severe abdominal pain. Porphyria can cause a recurrent abdominal pain. Lead poisoning, abdominal pain. So typically they have anemia, they have basophilic stippling, and they have abdominal pain. Uremia can present as abdominal pain. Coronary artery disease, radiculitis. Radiculitis means the ganglia in the posterior, you see, paravertebral ganglia when they are inflamed, or root of the nerve. So paravertebral root of the nerves when they are inflamed. Torsion of the testicle, pneumonia and herpes zoster. All these are truly not an abdominal cause, but still can present as abdominal pain. Okay, so I'll skip this. Now, pancreatic pain is a dull, continuous pain, mainly in the epigastrium, lasting for hours. It radiates to the back and aggravated by food. Relieved by sitting up or leaning forward, it is believed that leaning increases the space in the retroperitoneum. Because when you lean forward, what happens is the vertebra also bend, that increases the space in the retroperitoneum, and that leads to relief of the pain. So this is pancreatic pain. So how will you differentiate from gallbladder pain? Gallbladder pain may be in the right upper quadrant, but I told you in 25 to 30% gallbladder pain can be in the epigastrium. But typically remember, the gallbladder pain, the onset is very acute and the maximum intensity of the pain is achieved, or maximum intensity of the pain occurs within few minutes after the onset. But in pancreatitis, what happens is that onset is again acute, but the maximum intensity of the pain occur half an hour, 1 hour, or little more after the onset. So whereas gallbladder pain is like steep rise from the onset, the pancreatic pain is more like gradual crescendo and then going to the maximum. Okay, so this is the pancreatic pain and gallbladder pain difference. So what is colicky pain? This is a constant, or this is a question that we ask almost always. So what is a colicky pain? Here is the picture of the colicky pain. So in colicky pain, what happens is that the pain will rise, go to the maximum intensity, then will come down. Then again rise, go to the maximum intensity, and then come down. Again rise, go to the maximum intensity and come down. Now typically, this period of rise and going to the maximum intensity will be over maybe 10 to 15 minutes. Whereas then, the fall will occur. So how does it happen? It is like whenever there is a luminal occlusion, like shown in the picture by the side, whenever there is a luminal occlusion, intestine contracts. Intestine tries to overcome the occlusion. So when intestine tries to overcome the occlusion, the contraction of intestine lead to increase in the intraluminal pressure in the intestine. Also, contraction of the intestine causes increase in the intraluminal pressure, and that causes some degree of ischemia. And that is the reason why the pain occurs. But what happens is muscle contraction can be only for a while. It cannot be for long because muscle undergoes fatigue. Like if you remember muscle contraction, it occurs, but it requires a lot of ATP. So it requires ATP. So suppose if it keeps on contracting, it undergoes fatigue. Okay? During this fatigue, the intraluminal pressure actually decreases. Intraluminal pressure falls, the bowel ischemia becomes less, and the pain disappears. But again, when there is a resting phase, this resting phase leads to the muscle again regaining their ability to contract. And then the second contraction comes and again pain goes high. And typically intestinal contraction, if you sort of remember, intestinal contraction can be for 5 to 10 minutes. Like migratory motor complex of the intestine, duration of migratory motor complex is typically 5 to 10 minutes. That's why the period of pain is for 5 to 10 minutes. And then there is a fatigue. So if you ask the patient, did you have pain? Patient says yes. How long did the pain last? Patient says maybe half an hour to 45 minutes. Then you ask, was this constant throughout the half an hour to 45 minutes? Patient says no. Initially there would be pain. This will last for 5 to 10 minutes. Then it seems like pain got relieved. I was a little comfortable. But in 5 to 10 minutes again the pain came back and lasted for another 5 to 10 minutes. Now if you are getting this crescendo decrescendo pattern, this is colicky pain. That's why biliary colic is called misnomer, it is not a colic. Why? In biliary colic, pain rises, goes to a plateau, and then remain in that plateau phase. Now then it gets relieved. Typically biliary colic is not supposed to last more than 4 to 6 hours. If it lasts more than 4 to 6 hours, this will be called as, the biliary colic lasting more than 4 to 6 hours will be called as acute cholecystitis. So it is no more biliary colic, it is acute cholecystitis. On the other hand, biliary colic will be constantly there for a period of time as compared to the intestinal colic where you will get crescendo and decrescendo. Ureteric colic, severe colic pain starting in the loin, radiates to the groin and hypogastrium, genitalia and the medial side of the thigh. Why? Because if you know, the genital branch of the genitourinary tract supplies the genitalia. But from the same nerve, there is a femoral branch which supplies the medial side of the thigh. And these two nerves come from the lumbar plexus behind the kidney. So whenever there is some pathology in the kidney, the nerve gets irritated. Irritation of this nerve lead to pain in the genitalia because of genital branch of genitourinary nerve supplying there, and the femoral branch of the genitourinary nerve supplies the medial side of the upper thigh, and that leads to pain in the thigh. Okay, obviously ureteric colic will be accompanied by urinary burning and may even have hematuria. Stop for a while. Stop for a while. Stop. So now, let us now come to this table. This table is very important because I have been talking about pain, and in some cases I was saying pain is coming from the intestine. In other cases I was telling that pain is coming from the abdominal wall. So this is, when the pain comes from the intestine, it is called visceral pain. When the pain comes from the abdominal wall, it is called parietal pain. So how will you differentiate whether your patient has visceral pain or parietal pain? Visceral pain is dull, crampy, burning, gnawing, and poorly localized. So most importantly, visceral pain is dull and poorly localized. On the other hand, parietal pain is sharp and well localized. Onset, visceral pain may be more gradual in onset. On the other hand, parietal pain is more sudden in onset. Visceral pain will be in the midline, whereas parietal pain will get lateralized. That's why when somebody has pain in the gallbladder origin, it is a visceral pain. This visceral pain will maybe in the epigastrium because it is in the midline. This is a visceral pain. Similarly, in appendix, though appendix is located in the right iliac fossa, still the pain will be in the midline initially. Why? Because this is a visceral peritoneum which is getting inflamed, or maybe intraappendicular pressure is high because of a appendicolith there, and you will get a midline pain. Later, when the inflammation not only affects the visceral peritoneum but also parietal peritoneum, the pain will get lateralized, and the patient will say that the pain is now in the right iliac fossa. Secondary autonomic nervous system feature such as palpitation, sweating, tachypnea, all these will be more marked with visceral pain, less marked with parietal pain. Effect of posture, moving around in the effort to relieve in case of visceral pain. So visceral pain will give relief when the patient moves around. So patient will be rolling in the bed in agony. On the other hand, parietal pain, like let us say the patient, patient has an appendicitis, acute appendicitis. There is an appendicolith. This is distending the appendix. Distension will lead to visceral pain. The patient will be sort of restless, rolling on bed. Then suddenly appendix perforates, and then peritonitis sets in. Now the pain will now get aggravated by the movement and the patient will lie stand still. So when you see patient is lying stand still, bad thing has happened, appendix has got perforated. Okay? So these are the major differences. Similarly, along with pain, you can get history of obstruction. Like the patient that I presented, gave episode of intestinal obstruction twice. Now the obstruction can be proximal gut obstruction, it can be mid-gut obstruction, it can be distal gut obstruction. Proximal gut obstruction, typical example is duodenal obstruction. Mid-gut obstruction, typical example is right or other ileocolic obstruction. Distal gut obstruction typically is colonic obstruction. So site of pain in case of proximal gut pathology or obstruction is epigastrium, mid-gut periumbilical, distal gut hypogastrium. Vomiting will be marked in the proximal gut obstruction, less so in distal gut obstruction. Abdominal distension will be less marked with proximal gut obstruction, more marked with the mid-gut and most in the distal gut. Borborygmy typically will not be a feature of proximal gut obstruction, but will be a feature of mid-gut obstruction and distal gut obstruction. Obstipation. What is obstipation? It is like no passage of feces and platters will be more marked in the distal gut obstruction, less so in proximal gut obstruction. Visible intestinal peristalsis is a feature more of mid-gut obstruction than proximal and distal gut obstruction. Okay. So let us come back to our patient. Past and personal history is very, very important. Look at her personal history. She has 5 children. She is postmenopausal for 12 years. I told that there is no postmenopausal bleed. There is no significant past history. On general physical examination, there was mild pallor. Otherwise, everything was normal. There was no lymph node enlargement. Now, when we examine the abdomen, this is what we get. On inspection, there is nothing. So always abdominal examination should be inspection, palpation, percussion, and auscultation. Inspection, there was nothing. On palpation, there was no peritoneal sign, there was no hepatosplenomegaly. But on palpation, we found a lump. Lump is in the right iliac fossa. It is firm in consistency, round in shape, 10 into 10 centimeter. Margins are distinct all around. It is non-tender. There is no lobulation. The lump was quite freely mobile. It was not bimanually palpable and ballotable. Renal angles were not full, and the lump was becoming more prominent in knee elbow position. So all this must be noted during the examination. Why? I'll show you a table to substantiate that later. Percussion did not show any free fluid. On auscultation, there was no rub, no bruit. Perrectal examination was normal. Pervaginal examination was normal. So in a patient of abdominal lump, perrectal examination is must. Pervaginal examination is also necessary. Now on abdominal examination, as I told you, you should do inspection, palpation, percussion, and auscultation. On inspection, in a patient, not in this patient obviously, you can get prominent abdominal vein. For example, in this particular figure, this is a patient of portal hypertension, and you can see caput medusae. Here, there are dilated vein. These are caput medusae. What is caput medusae? Caput medusae is a portosystemic anastomosis. So what is the portosystemic anastomosis here? From the systemic side, you have superficial epigastric vein and superior epigastric vein. From the systemic side, you have superficial epigastric vein and superior epigastric vein, which are branches of internal thoracic vein or internal mammary vein. Okay. Now from the portal side, these are paraumbilical veins of Sappi. Paraumbilical veins of Sappi are in the free edge, are in the falciform ligament, Now, they are, if you see falciform ligament, they run by the side of falciform ligament, and then they anastomose, or they go to the left branch of portal vein. Now, therefore, what does it mean? That if the fellow has an extrahepatic portal venous obstruction, you cannot get caput medusae. Why? Because if the portal vein is blocked, most of the time portal venous obstruction, almost in 99% of the cases, either is in the confluence of the splenic vein and superior mesenteric vein, or in the main trunk of portal vein, or is in the bifurcation of portal vein. So if these are the areas blocked, no way the portal blood could be bypassed in patient of portal hypertension to the systemic circulation by these collaterals. So that's why you cannot get caput medusae in extrahepatic portal venous obstruction. 1% of the patient have extrahepatic portal venous obstruction where only the left branch of the portal vein may be blocked, and there you can get caput medusae, a rare occurrence. So therefore, for all practical purpose, caput medusae exclude extrahepatic portal venous obstruction. The same is shown here, the site of the block that I told you. So I was talking about all these features that you should examine in the lump. What are these features? The features are, look at the lump, whether it is firm, whether it is round, what is the size, how is the margin, can you feel all the margin, is it tender or non-tender, is there lobulation, is it freely mobile, whether it is bimanually palpable or not, whether it is palatable or not, what are the about renal angle, are they free or foot, whether lump become more prominent in knee elbow position or not. Why do you say all this? You say all this because you have to know whether this lump is parietal lump or intra-abdominal lump. In intra-abdominal lump, further you have to know, is it a retroperitoneal lump or intraperitoneal lump? When you get a case of abdominal lump, a practical tips is that don't give only all your emphasis on the history, because history can be fallacious. History patient may not recall properly. So therefore, you analyze the lump very, very carefully, and after your analysis of the lump, base your diagnosis to a large extent on the feature of the lump and take history as the secondary measure to support the diagnosis, rather than forgetting all the findings of the lump and going to let us say history. Let us say a patient gave history of right upper quadrant pain which was sudden severe. Okay? Now what happens is, this looks like biliary colic, but you get a retroperitoneal lump, but you diagnose this patient as gallbladder cancer. So there is a difficulty, because gallbladder cancer will be normally an intraperitoneal lump, because the gallbladder is within that cavity. So therefore, it will be good to give a lot of value to the lump finding. So this is all about the retroperitoneal, intraperitoneal lump. This is the peritoneal compartment. If you remember peritoneal reflection, this is the parietal peritoneum that covers the inner side of abdominal wall. Then near the bare area of the liver, it reflects back to cover the liver on its anterosuperior surface, go to the base of the liver or inferior surface of the liver. Then from around the caudate lobe, actually this peritoneal reflection becomes the anterior leaf of the lesser omentum. Also there is a posterior leaf of the lesser omentum. So now you see, what you see is that the lesser omentum is encircling the stomach. Now subsequently from the greater curvature of the stomach, it is coming down as the greater omentum. It is coming down as the greater omentum. Then the greater omentum is encircling the transverse colon. And from the transverse colon, it is going as a transverse mesocolon to the anterior surface of the pancreas. Now behind the stomach, that cavity is called lesser sac. And anterior to the stomach, the cavity is called greater sac. So lesser sac and greater sac. All these are intraperitoneal. So what is retroperitoneal? Retroperitoneal is behind the peritoneal reflection in the back of the abdomen. In the back of the abdomen or in the parietal layer in the back of the abdomen, the peritoneal covering behind that all is retroperitoneal. So to tell you what a retroperitoneal structure, for example, pancreas is retroperitoneal. For example, kidneys are retroperitoneal. For example, adrenal is retroperitoneal. Third part of the duodenum is retroperitoneal. Ascending colon is retroperitoneal. Descending colon is retroperitoneal. So you can see in the cross-sectional anatomy given on the right side what are the structures that are retroperitoneal. So aorta is retroperitoneal, IVC retroperitoneal, kidney retroperitoneal, suprarenal retroperitoneal, pancreas retroperitoneal. Okay, so these are all retroperitoneal structures. So we are trying to differentiate whether the lump is intraperitoneal or retroperitoneal. Go next. 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 Now first you have to say, is it a parietal lump or is it an intra-abdominal lump? So is it a parietal lump or is it an intra-abdominal lump? Let me tell you, for all practical purposes, parietal lump will not be sort of given to you to examine, for example, in an examination. Normally would not be given to you. But suppose if there is a superficial lump which looks like parietal, it is better to do this test. So what is this test? This is leg raising test or a head raising test. So palpate the lump first. After palpation of the lump, you ask the patient to raise the leg. Raise the leg. And you see, did the lump become more prominent or less prominent? If on raising the leg, the lump became more prominent, this is a parietal lump. If on raising the leg, the lump become less prominent, it is intra-abdominal lump. On raising the head, if the lump became more prominent, it is parietal lump. On raising the head, if it becomes less prominent, it is intra-abdominal lump. So first job is to say, is it parietal or is it intra-abdominal? Then second job is, if it is intra-abdominal, is it retroperitoneal or intraperitoneal? Go to the next. So in parietal lump, I showed here that parietal becomes more prominent on leg raising, intra-abdominal becomes less prominent. Movement of the respiration is less marked in parietal, more marked in intra-abdominal. Percussion note may be dull or is dull in parietal, resonant or dull in intra-abdominal. But most important is the first row. Go to the next. Go to the next. Go to the next. Or next. 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 I have to see where is this chart. Next. जाते रहो दे बताएंगे next. अभी भी जाना पड़ेगा. अभी भी जाना पड़ेगा. अभी भी जाना पड़ेगा. Where is this chart one? Go further. Go further. Go further. Go further. Yes. That's all. Not previous. So this is the chart to differentiate retroperitoneal and intraperitoneal lump. This is very, very important. For example, retroperitoneal lump is deep, not easily palpable. Intraperitoneal lump is more superficial and easily palpable. Margins are poorly defined in retroperitoneal. The reason is it is not very easily palpable, that's why. Whereas intraperitoneal, margins are well defined. Movement with respiration, intraperitoneal lump often moves with respiration. Retroperitoneal lump may not move with respiration. Exception are kidneys. Kidneys are retroperitoneal lump, but they show some degree of movement with respiration because we all know kidneys are inside the fossa of Gerota, and the fossa of Gerota is connected to diaphragm by phrenorenal ligament. Phrenorenal ligament. Renal obviously means kidney and phreno means diaphragm. So kidneys are within the fossa of Gerota. The fossa of Gerota actually is connected to the crus of the diaphragm by phrenorenal ligament. That's why though kidneys are retroperitoneal lump, but they move with respiration. Intrinsic mobility. What is intrinsic mobility? When you catch the lump with a hand and try to move. Intrinsic mobility is there with intraperitoneal, but is not there with retroperitoneal. Ballotability is there with retroperitoneal, not there with intraperitoneal. What is ballotability? Ballotability means you put your hand below the lump on the back, you put the other hand anteriorly over the abdomen, then push the lump from the back, and if the lump touches your anterior hand and then fall back on the other hand in the back, this is ballotable. So ballotability is a feature of retroperitoneal lump, but not intraperitoneal. Bimanual palpation, you touch the lump with your hand on the back, you touch the lump with hand in the front of the abdomen, and if you can see with or feel with both the hand, the lump is palpable. This is a bimanually palpable. Bimanual palpability is a feature of retroperitoneal lump, but not intraperitoneal. But remember, if the lump become very large, it will become bimanually palpable, but it may lose its ballotability. On the other hand, if a lump is very ballotable, it may not be always bimanually palpable because it is small. Knee elbow position. Ask the patient to sort of be on knee and elbow, kneel down type. So knee and elbow. Ask the patient to be on his or her knee and elbow. Now in knee elbow position, retroperitoneal lump doesn't fall forward. So palpate the lump while the patient is lying down. Then ask the patient to be on knee elbow. Again palpate and see, did the lump fall forward? If it is falling forward, it is an intraperitoneal lump. If it is not falling forward, it is not an intraperitoneal lump. It is likely to be a retroperitoneal lump. Remember one thing, some patients are sick. They may not be in knee elbow. Just ask them to be in the left lateral and right lateral and see what is happening to the lump. Now even by right lateral and left lateral, you can make out whether the lump is falling or not on the lateral side and get an idea whether it's intraperitoneal or retroperitoneal. Now observe the renal angle. So on the back side, observe the renal angle. In case of retroperitoneal lump, renal angle may look quite full. On the other hand, in intraperitoneal lump, renal angle obviously will be empty. You percuss over the lump, retroperitoneal lump will be resonant. Why? Because in front of the retroperitoneal lump there are intestinal loop. Whereas in case of intraperitoneal lump, it will be dull. Prototype of retroperitoneal lump is retroperitoneal sarcoma, and prototype of intraperitoneal lump, let us say gastric tumor, let us say gastric tumor is the classic one. Let us say small intestinal tumor or small intestinal masses, they are intraperitoneal. Now remember one thing, lesser sac is an intraperitoneal structure. Lesser sac is an intraperitoneal structure. So when you get pseudocyst, though this is an intraperitoneal structure, it behaves like retroperitoneal. That means it will not be very well mobile, mobility will be less, it may not move with respiration, it may not fall forward in knee elbow. So the lesser sac is an intraperitoneal structure, but it may behave like retroperitoneal. Classic example, pseudocyst. On the other hand, some of the kidney lump, though they are retroperitoneal, may behave like intraperitoneal, and there may be confusion. Go back. Okay, so now remember, when you think about the diagnosis, in a patient of abdominal lump, this chart will look silly to you. This chart will look silly to you, but I tell you this chart is very, very important. Let us say you get a lump in the right lumbar area on the upper side. So upper part of the right lumbar area. Now you will talk about gallbladder, I know. You will talk about ascending colon, I know. But you will forget about suprarenal. The moment you forget about suprarenal, you are in difficulty. So that's why anatomically go back. Remember what all structures are there in what location. Go back. 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 Further. 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 So this is very, very important. So what you do is that you make this sort of figure. It looks very silly, but most of the students actually make a mistake there. Let us say there is an adrenal lump and this is given in the exam, and the fellow will say, yes sir, the lump could be from the ascending colon, the lump could be from the hepatic flexure, the lump could be from the liver, the lump could be from the gallbladder, but he forgets to tell that lump could be from the kidney and lump could be from the adrenal. Now obviously this is a gross discredit. So therefore, if you remember your anatomy days, what teacher used to ask you, if I stab the fellow on this location, if I stab this fellow on this location, what all structure will be pierced? This was a classic question in anatomy. The fellow is stabbed in one location, what all structure will be pierced by that knife, and this will tell you that what will be your differential diagnosis. So when you make the diagnosis, first part of the diagnosis is if there is a lump, is it a retroperitoneal lump or is it an intraperitoneal lump? Second thing will be, what is the likely organ from which the lump is originating? Third will be whether it will be malignant or benign. For example, the fellow is elderly, fellow has anorexia, weight loss, you will say more likely malignant. And if these are absent, you will say more likely benign. Then you say what could be the diagnosis. So a classic diagnosis will look like a patient with retroperitoneal lump in the right iliac fossa, possibly malignant in nature, possibly arising from the cecum, appendix or the ascending colon, and possibly it is CA, ascending colon and cecum. This is the diagnosis without any extra intestinal spread such as hepatic spread or something like that. So this is how diagnosis has to be presented rather than saying that said this is a patient of CA colon. Because if you say it is an appendicular lump or cecal lump or in the ascending colon lump, you are more likely to be right than CA colon. Okay? Then if you say the lump is more likely to be malignant than benign, you are more likely to be right. Now if you say it is a ascending colon cancer, you may be wrong. It could be an ascending colon lymphoma. Okay? Now next. आगे बढ़ते हो. आगे बढ़ते हो. आगे बढ़ते हो. Now let us say we talk about this patient. So I told you this patient presented with a lump in the right iliac fossa, which was for 6 months. It got increasing, or it was increasing in size more fast for last 3 months, with 2 episodes looking like subacute intestinal obstruction. She had some anemia. There was no postmenopausal bleed, and she did not have anorexia and weight loss. So what is the differential diagnosis? Differential diagnosis, or what will be the diagnosis? Diagnosis would be, and the lump on examination looked more like retroperitoneal. The lump on examination looked more like, no, intraperitoneal. Can we go back? Keep on going back. Keep on going back. बताने का जरूरत नहीं, जाते हो back. Yate. 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 Pura. Yate hi lo. Hum dekhen. Yeah. So this one. So this was a lump which was firm, round, 10 into 10 centimeter. Margins are distinct all around, non-tender, no lobulation, freely no mobile, not bimanually palpable, palatable. Renal angles are free, becomes more prominent in elbow position. This is an intraperitoneal lump. So you have a patient who is 55-year-old female, has an intraperitoneal lump in the right iliac fossa with some anemia, with 2 episodes of subacute intestinal obstruction. So what was the diagnosis? Diagnosis is looking more like benign. You know why? Why looking benign? Because she has only mild anemia, nothing else. Age is for malignancy, but other features are for more benign, but okay. Now this looks like intraperitoneal lump. If it is intraperitoneal, my suspicion will be the lump has to be either from the idiom, or has to be from appendix, or it has to be from cecum, which has a mesentery. So there could be the anatomical variation in the cecum. Some people's cecum can have a mesentery, in which case you can get a cecal lump, but it could be intraperitoneal type. It could be an appendicular lump, because we all know appendix is usually intraperitoneal. It could be an ileal lump, because we know ileum is intraperitoneal. Look benign. So what is the possibility? Because it is 6 months, it can't be appendicular lump. Like following appendicitis, there could be a lump, but the history is too long. It could be, yes, it could be a tuberculosis, it could be Crohn's disease, it could be mesenteric cyst, it could be appendicular tumor, not appendicular lump like following acute appendicitis, it could be appendicular tumor, because I can freely see all around the mass. It is unlikely to be ovarian mass, because ovarian mass I can't feel the lower margin very well. So this is where the diagnosis will be. So diagnosis will be right iliac fossa lump, intraperitoneal in nature, possibly benign, arising either from the ileum or from the appendix or from the cecum, which has a mesentery. It could be also mesenteric lump. Okay, the possible etiologies could be tuberculosis, Crohn's disease, mesenteric cyst, okay, and maybe appendicular tumor or something like that. So this is where we keep the diagnosis. Go next. आगे बढ़ते हो. So investigation, yes, go back. Investigation, hemoglobin was normal, so what we thought is anemia clinically was not there. Total leukocyte count is normal, platelet is normal, ESR is a little raised, bilirubin normal, albumin little low, SGPT normal, prothrombin time normal, creatinine normal, urine microscopy normal. Next. Now on ultrasound, we found that chest abdominal X-ray normal except some calcification on the left side, doesn't mean much. On ultrasound, there was a lump in the right iliac fossa with multiple internal septa. There was no calcification and there was some free fluid. So it means, yes, what we are keeping in the differential diagnosis, all are possible. It could be a mesenteric cyst, I agree. It could be an appendicular lump. Okay, it's like appendicular tumor, not appendicular lump. It could be an appendicular tumor. Go next. Now, we did a barium, or barium she was carrying, and you can see there is a soft tissue shadow in the right iliac fossa. That means in the right iliac fossa, I can't see cecum very well. There appears to be a soft tissue shadow, and it looks like ileum is going up to open into the cecum. So there must be some soft tissue lesion there. Next. Colonoscopy was next. Now this is very important. Now on CT scan, there was irregular soft tissue density mass with heterogeneous enhancement with some free fluid, and this is in the right iliac fossa region. So basically what we are suspecting is it a cystic lesion that is substantiated? It could be coming from appendix or from the cecum with a mesentery. Yes, next. Colonoscopy was normal. Now what we did is, next. What we did is we actually tried to do a fine needle aspiration or an aspiration from that mass. And what aspirate came out to be a jelly-like material. And this jelly-like material means this was pseudomyxoma peritonei. So this was a patient of pseudomyxoma peritonei, and we all know pseudomyxoma can arise from the gallbladder, it can arise from the appendix, it can arise from the cecum, and this is a patient possibly with a cecal pseudomyxoma, or it is a patient with appendicular pseudomyxoma. Okay, pseudomyxoma, though it is a malignant disease, but it is a very slow growing lesion and therefore it can behave like benign. So that's why what I said is be like a fisherman, open your net wide, your base should be very wide so that you don't fall. It should be like a pyramid. Clinical diagnosis should be like a pyramid rather than reverse pyramid. Pyramid means base is so wide that you say there is an intraperitoneal lump in the right iliac fossa, possibly benign in nature, possibly coming from appendix or ileum or cecum with a mesentery, and the pathology could be this, and give 10 possibilities in pathology. Thank you so much.